Welcome everyone to Nutrition Live, coming to you from unusually warm and sunny Cleveland, Ohio. We're excited to have so many of you join us tonight. Next slide. My name is Renee Welsh. I'm one of the program co-directors along with Dr. Kirby. Next slide, please. And we are thrilled to welcome over 806 healthcare providers joining us from over 63 countries. We're very grateful that you took some time this evening to join us, and we're looking forward to a fantastic presentation. I'm going to hand it off, next slide, to Beth Czerwony, who's our moderator for tonight.
Hi, welcome everyone. If you have any questions during the presentation, please type in the chat as the presentation goes on. We will have co-moderators to help convey the questions to the presenters. At the end of the presentation, we will be providing a QR code for you to obtain the CME CPEU Certificate of Attendance. If you have any questions accessing that code, please let us know. This session will be recorded. Only the live session will be eligible for CME CPEU credit. Viewing the recording after will not qualify. With that being said, it is my pleasure to introduce Dr. Stephen Loop, Dr. Madison Simmons, and Kendra Weekly, who will be speaking about the gut-brain connection. Dr. Stephen Loop is a recognized leader in digital health and section head of behavioral health in the Cleveland Clinic's Department of Gastroenterology, Hepatology, and Nutrition. He established and directs an internationally recognized integrative behavioral medicine program, expanding it to include 9 psychologists, 4 dietitians, and a digital health partner to improve access to care. This model has become a blueprint for scaling whole person, team-based care. As co-inventor of the Able Health digital care platform, Dr. Loop is at the forefront of developing digital innovations and collaborative care models that expand access, improve patient outcomes, and reduces costs for individuals with chronic health conditions. He has also advised multiple industry partners, helping to shape the future of high-quality, whole-person digital and in-person care delivery. Dr. Simons is a GI psychologist in the Department of Gastroenterology, Hepatology, and Nutrition at the Cleveland Clinic, where she specializes in treating disorders of gut-brain interaction and motility-based GI conditions. Her research and clinical interests include precipitants and consequences of dietary modifications in patients with digestive symptoms, including the development of food-related anxiety. And Kendra Weekly earned her Bachelor of Science degree in dietetics from the University of Akron and her master's degree in exercise science and sports nutrition from Concordia University in Chicago. A Cleveland, Ohio native, Kendra has proudly served as a dedicated member of the Inflammatory Bowel Disease Medical Home at the Nutrition Clinic, at the Cleveland Clinic rather, for the past 4 years. Her professional experience spans diverse populations, including geriatrics, pediatrics, and adults, currently with a primary focus on gut health and gastrointestinal disorders.
So we're going to be having a conversation about this relationship between the brain-gut axis and how nutrition sits on top of that. And so we're going to start in a more broad sense and then dial it into this kind of miscommunication that can occur between the gut and the brain. So I'm going to turn it over to Steve to lay the foundation for our conversation.
Sure. So, the reason we talk about this whole brain gut thing is it turns out the gut's a really, really complicated place. That your brain and gut are constantly talking to each other. The enteric nervous system and the central nervous system develop at the exact same time when we're developing inside our mother. But the more we look at this, the more complicated it gets, including the fact that there's this thing now called the gut microbiome that we're all starting to talk about. And it turns out that may be controlling a lot of our mood and memory. And then the things that are going on in the central nervous system control the functioning of the gut a lot of times. And you can get discommunication between the two so that the message going up to the brain is not read correctly. And the brain will then send down messages about altered functioning that don't help the gut necessarily. We'll go to the next one.
And so we're going to start this conversation from the premise of what we would call disorders of gut-brain interaction. Clinically, what this looks like is patients who present with symptoms and all of their procedural results may come back normal. And so we have a functional impairment, but not an organic GI condition. And this is important for us because many of our patients, even with organic conditions, may present with an overlapping disorder of gut-brain interaction. These conditions are characterized by the presence of visceral sensitivity, which is increased nerve communication coming from the gut up to the brain. Think of this like having burned your arm on the stove. Normally, your shirt doesn't hurt you. We're not aware of our shirt on our body in most cases. But if we had burned our arm on the stove, we would be acutely aware of any sensation on our arm, even the softest material. That same sensation can take place inside the GI tract, where sensations that used to be normal, such as the passage of food or liquid or stool or gas, now are perceived as uncomfortable or painful. In a disorder of gut-brain interaction, we also see changes in motility, how quickly things transit through the GI tract, changes in overall immune function, and changes in how the central nervous system processes information throughout the whole body. Why this matters from a nutrition standpoint, I'm going to give us an example here. Like Steve said, by nature of there being a disorder of gut-brain interaction, we understand that the signal being sent from the gut is not always accurate, and therefore the brain cannot make the correct behavioral response. For example, many of our patients may experience hunger inaccurately as nausea or pain. And so if I experience nausea from my GI tract, my natural response is not going to be to eat food. When in fact, the GI tract is maybe screaming, please feed me. And so I have the incorrect behavioral response to continue not to eat, but the sensations coming from my gut get louder and louder, and it feeds this reciprocal loop. And so our job is to help patients learn to understand these signals that are being sent and still make a behavioral choice that fuels their body.
And so let's spend a second here talking about hypervigilance and symptom anxiety. So anxiety is a normal response when we are experiencing GI distress. Your brain is trying to solve that constantly. And what happens with that, because the brain is so centered on how do I solve these sensations in the GI tract? How do I make these things better? And think about how much this can impair someone's life. A lot of times people have to know what their gut's doing so that they can plan out their day. The brain like almost turns up the volume on these sensations, and with that we start worrying about it more. It's this vicious cycle loop. So you see GI symptoms come up because there's a lot of anxiety, a lot of stress on the body, activation of the sympathetic nervous system, and with that then people will shut down their life because they focus so much on the symptoms themselves, and it takes over in our brain's ability to predict symptoms. I talk about it all the time. Almost every patient I work with knows every bathroom between them and the Cleveland Clinic. And that's because the brain's ability to predict what's coming and make it real before it happens. So there's this idea of cognitive flexibility. So cognitive flexibility really is the ability to step into the moment with whatever is going on and see that you have choices in your behavior. And so with cognitive flexibility, we're going to have more options. When people have GI symptoms, cognitive flexibility usually goes out the window. And Dr. Simons and I spend a lot of time teaching people cognitive flexibility skills, because when a GI symptom shows up, our behavior goes under this control of like, it's trying to avoid bad. It's like if a bear walked into the room, right? If a bear walked into the room that you're in, you probably wouldn't notice the artwork on the walls. And you'd really have only two options to fight or flight. However, if you like wander around and find a blueberry bush, right, there's no threat. It opens back up. You can see all these things. And we will be reacting to things that aren't happening yet and having that kind of closed response down there. And that's what's happening with this inability to shift attention, to shift perspectives. That's because the behavior has shut all the way down. And what we spend a lot of time doing then is teaching people even to see their thoughts as thoughts, to see the predictions as predictions, to see sensations as sensations, so that we can open this up and make some choices.
Since we're having a conversation tonight around the context of nutrition with the gut-brain axis, we're going to talk about how the gut-brain axis can really lead us astray from a nutritional standpoint into the realm of food avoidance. And that's where part of our conversation is going to linger today. And so I want to start us with this idea that food avoidance is evolutionary. This is integral to our survival as a population. And we see this even in animal studies. There was a study that came out just within the last year where they gave rats, they gave them two different groups of food, novel flavors and familiar flavors. And both of these were paired with an emetic agent, an agent that would make them sick. The rats who were presented with a novel flavor and an emetic agent were not likely to return to that novel flavor again, but the rats who had received a familiar flavor with the emetic agent would later return to that food product. And I think this really speaks to how our brain is hardwired to associate food and symptoms, especially if it's in a new condition. And so I want to start in this space with our GI patients, who many of them experience symptoms after eating. And we might start to question, is the amount of food avoidance that they're displaying normative? Is this adaptive, or is it problematic? And that starts to raise the question of something considered to be avoidant restrictive food intake disorder, which we're going to talk about shortly. But I think as providers, it's so important for us to remember this would be a normative response to having significant GI distress associated with eating. The other bias that we might want to check within ourselves is we might ask the question, is diet being used to manage the symptoms that a person experiences, or is it being used to manage disease activity? And I think this question is most prominent in our patients with something like inflammatory bowel disease or even EOE, conditions that can be diet managed. A patient with inflammatory bowel disease, if they were to present to us and say that they're following a specific carbohydrate diet or the Crohn's disease exclusion diet, both of which are highly restrictive diets, we might actually praise them or admire them for their ability to follow this diet and help their body toward remission. But if we had an patient with irritable bowel syndrome who presented saying they were following a diet as restrictive as that, our instinct or our bias might be to start to feel concerned, because we would say it's managing symptoms, it's not managing the disease activity. So we do just want to check in on what our own bias is as to what we consider to be an acceptable level of dietary restriction, and ensuring that we're coming at this from a compassionate standpoint. Avoidant restrictive food intake disorder has garnered a lot of attention over the last 5 years or so, and the estimated rates of what we might consider to be pathologic avoidance really vary based on which population we're studying. In a general GI population, we might see 15 to 20% of patients screening positive for ARFID, 40% of patients with motility disorders, and it could be upwards of 50 to 80% of patients with organic GI conditions like IBD, celiac, EOE, screening positive for ARFID. What we're looking at in ARFID is food avoidance or restriction that is due either to the lack of interest in food or eating, the aversion to the sensory characteristics of food, or aversion to or avoidance of the aversive consequences of food and eating, such as having diarrhea or vomiting after eating. And this can be associated with nutrient deficiencies, profound weight loss, or the need for supportive nutrition, or even psychosocial impairment. I'm starting to avoid social eating experiences. And so these studies that have come out are based on this screener here called the 9-item ARFID screen. And you'll read these today, and in particular, the last 3 items really focus on that fear of eating because of my GI symptoms. I avoid or put off of eating because I'm afraid of the discomfort that I'll have. I restrict to certain foods because I'm afraid other foods will cause symptoms. And I eat small portions because I'm afraid of discomfort. Well, when we ask these questions based on the particular condition, I'm thinking at gastroparesis, for example, it's actually very adaptive for us to eat small portions. or it might be adaptive for us to restrict to certain food items. And so these rates that we present on the screen here that have been published in the literature may actually over pathologize what could be an adaptive level of food avoidance. And so our conversation today is going to center around the idea of food fear, even if it doesn't meet pathologic restriction. GI symptoms after eating can be related to a variety of different factors. Our patients often think of the first point here, nutrient-based factors, that when I put a specific nutrient in my mouth, that I will have GI symptoms every time. And this may be the case for someone who can't tolerate dairy or who has celiac disease, then the wheat is what is causing the symptoms. Our brain very naturally makes these food symptom associations, but there are other factors that may actually even play a larger role, such as the volume or the consistency or the timing of the food that I eat that has nothing to do with the actual foods that I put in my mouth. There could be a level of underlying GI dysfunction that changes my body's response to food. It could be that visceral sensitivity, that heightened communication of the GI nerves up to the brain, or the role of expectancy around food and eating. What I anticipate will happen to me can play a role in my symptoms.
The way I always word this, the role of fear in symptoms of restrictive eating, it's no wonder when you back up and look at what's happening. Like if every time that you put broccoli in your mouth, I shocked you, right? How long does it take for you to say, I'm not eating that anymore? And we make these associations very, very, very quickly. And then what happens is fear sets in. And we have almost like patients will almost have like a trauma response a lot of times to food. So even if like Kendra, David, any of the dietitians say, this is what we need you to eat, a lot of times then our job is to figure out how do we do that? How do we move around fear around food? How do I get you to start integrating more fiber-filled foods, vegetables, fruits back into your diet? Because we know that those are helpful for overall nutrition. They feed the gut microbiome and everything else.
The idea with fear of symptoms is if I can't tolerate the symptoms that might come up when I eat, I'm going to be very unwilling to take risks around the eating experience. And so there may be a role with patients of increasing that sense of distress tolerance. Do I feel like I can manage symptoms when they come up? If I don't feel like that, we're going to probably have very little movement with food exposures or reintroduction. There have been a handful of studies similar to this design that have come out and are actively in the works. And this, the study that I'm going to talk about here really demonstrates this role of expectancy versus actual consumption. In this particular study that was presented at DDW a couple of years ago, they took patients with non-celiac gluten sensitivity and they broke them into two groups. Those that believed that they were going to be eating gluten-containing bread and those that believed they were going to be eating gluten-free bread. And within those two groups of expectancy, half of the patients actually received gluten and half of the patients did not receive gluten. And so you can see here the four groups that you ended up with: people who expected gluten and got it, who expected it and did not get it, who did not expect gluten but did get it, and those who did not expect it and did not get it. And what these authors found was that the biggest difference was whether the person expected that they were receiving gluten or they did not. And within these groups, based on gluten exposure, there were not significant differences in symptoms associated with that trial. And so what this study brought to highlighted is that the nocebo effect, or what I negatively predict will happen, plays a significant role in symptom occurrence in patients with non-celiac gluten sensitivity. And I think this could probably extend into other conditions as well, but it really highlights that the act of digestion may begin long before I actually put that food into my body. From the moment that my eyes recognize the food or that I start to consider the thought of food into my brain, I may be beginning that digestive process.
And you'll see that with patients all the time, right? These patients, I can even do it in my office where I go, if I gave you a salad right now, what would happen? And immediately they're like, I'd get diarrhea, I'd be sick. And it's like, wow, check that out. And they may even start experiencing distress just from talking about it. Um,
Yeah. This has also been outlined in another visual picture that I like from Wendy Boosie, a dietitian in Canada, has really put out this model of conditioned food sensitivities. And she describes how we can start with symptoms after eating. And that leads me to either being mistrustful of my own body, like my body can't handle it, or I'm mistrustful of the food. And I will say I more commonly see mistrust of the food than I do the belief that my body isn't handling it. And so that leads me to avoid certain foods, and maybe temporarily my symptoms improve. This reinforces that food is, in fact, something that's dangerous for me. And so that starts to create this overactive nervous system, that fight or flight response around food and eating. When my nervous system becomes hypervigilant around the experience of eating, I'm going to experience GI symptoms just by nature of my nervous system kicking in. I may have more rapid motility or delayed. I might feel nauseous, get indigestion. I may even vomit. But I'm also likely to experience symptoms that could feel even like an allergy or food intolerance, things like difficulty breathing or my heart starting to race. I could develop hives. And so this reinforces this cycle that food is dangerous when I may be getting symptoms as a byproduct of this hypervigilant nervous system, or what she calls a conditioned food sensitivity.
And the expectancy around food and eating is going to shift everything that's going on. So if I become very nervous about eating a food, and that's going to just shut down what's going on, and it's going to promote hypervigilance. So what you see is that people will start monitoring for the GI symptoms when the food shows up. It's automatic, right? I know this is going to make me sick. I know it's going to make me nauseous. I know it's going to make me hurt. Um, they start monitoring for it because they're looking for that to show up because there's an expectancy of it, which they then feel the change, the sensations start to show up, which increases anxiety, and that turns that volume up, like I said, on symptom severity. And this is kind of a vicious cycle that we see all the time.
When we're thinking about the idea of whether avoidance is adaptive or it might be problematic, I'm thinking about avoidance as a key maintaining factor in symptom anxiety. And these are some of the flags that might stick out to me, as if a patient describes avoiding broad food groups, not just specific foods within it. I'm avoiding foods because of the possibility of symptoms. They haven't actually happened in the past, like here, without a consistent history of associated symptoms. I'm continuing to avoid foods despite having minimal symptom improvement on the diet. And this comes up like when our patients are following a low FODMAP diet. We generally recommend that elimination phase lasts three weeks or so. And if no difference has happened, then we encourage resuming a normal diet. But patients might hold out hope that diet is eventually going to make a change and maintain the strict elimination phase. And we might see patients who have significant hesitation around food reintroduction, whether their symptoms have improved on the elimination diet or not.
Dr. Simons, I just wanted to ask quickly, what do you think the role of anti-nausea medication is when you're trying to reintroduce these foods into their diet? Have you done this? Do you feel that it's problematic, or do you find that there's some benefit to it?
Yeah, good. Can I put a pin on that and address it in like just a couple of minutes as we think about this scale? Because I think that's a great question, is like, what is the role of rescue medications? I'm a huge advocate of rescue medications, especially in the early phases of exposure. And I'll talk about that when we get into how do we rewire this connection. Part of what we, go ahead, Steve.
No, go ahead. No, go ahead. Sorry.
Part of the message we want to help our patients arrive to eventually. Maybe it's done explicitly, but on a lot of times we want them to learn this through experience, is pain or discomfort does not inherently mean danger to my body. And I think this really depends on which condition you're working with. In our patients with celiac disease, they might become ingrained that a gluten contamination is what causes my pain or discomfort. And so if I have pain or discomfort, it means I've been gluten contaminated, and that is dangerous to my body. When in fact, they could have an IBS overlap onto their celiac. They may not have been gluten contaminated, but they experience pain. And so it's really difficult to sort through for them. Is this pain dangerous, or is this uncomfortable to me? And so as much as we can as treatment providers, we want to help patients understand, when does pain mean danger, and when is pain uncomfortable, unsettling, and something that, will resolve in time.
And that can be a really hard, like, line to walk. I predominantly work with patients who have been diagnosed with inflammatory bowel disease, and we see it all the time in patients who have experienced bowel obstruction or stricture, that as soon as they experience pain, that means I'm getting another stricture again. And even if the testing evidence doesn't support that, a lot of times they will limit down their diet to soft foods and smoothies because they're scared that they're going to have an obstruction or stricture that will wind up in a hospitalization or an ED visit. And that's hard. And part of that is what we're talking about here. How do you break that cycle of avoidance? How do you break this? So the amygdala, which is the threat detector in the brain, is highly experiential driven. So like I was saying, as we have that anxiety, as we have these symptoms, it goes farther this way. We get more of a sympathetic response. And as we have to reprogram that by creating more and more good responses and pairing it with things, even like relaxation, hypnosis, stuff like that, so that we can try to reprogram this thing. The amygdala was not designed to be real rational either. It was designed through evolution to deal with threat. That if like I said, a bear walks into the room, my attention locks down, I figure out what I'm going to do about it, like yesterday. And it doesn't involve a whole lot of rational thought. It actually takes time to slow someone down to have rational thought and overcome that. But the goal of exposure really is to get those positive experiences back paired with this, like eating. In what Dr. Simons was even saying there about rescue medication, right? If we can create those positive experiences, if we can create the context for that to show up, then it's probably useful.
Absolutely. So we think about, like, in expanding someone's diet out, I have a series of goals. My first goal is not expanding the diversity of the foods that they're consuming. Their brain is too vulnerable to making negative food symptom associations. And so I always defer to starting with the foods that they're already eating that they feel relatively safe with. And we're increasing the frequency of those foods so that I'm eating them more often through the day. And then I might push on volume just slightly, eating another bite or 2 bites beyond that. And only then am I going to start to practice expanding diversity. Once those things have started to happen, then we might think about this last variable, which is a little more cognitive in nature. You might find patients are eating a good caloric intake, they're eating a diverse range of food, but they are spending all day long thinking about and planning about food and eating. This is still a patient who experiences functional impairment, is to say, eating controls my life. And so we want to eventually help them find flexibility in their ability to plan around food and eating. And like we talked about in the last slide, our goal is to accumulate as many neutral or positive experiences around food and eating as possible. In this early stage, that might mean that I'm only putting 1 or 2 bites of food in my mouth at a time, reinforcing to the brain that eating may not be as dangerous as I had previously expected it to be. And so I talk with patients about this idea along a ladder, where at the bottom of the ladder, we have what I would consider to be low risk exposures. And at the top of the ladder are high risk exposures. And sometimes our patients have very black and white thinking. as far as I either need to be able to eat at the restaurant with all my friends and eat the whole plate, or I like shouldn't do any of that at all. And so part of what I want them to see is there are a lot of different ways that I can vary the amount of risk associated with an experience, but we only want to change one of these at a time. So I've listed here some of these, like who I'm eating with, where I'm eating, how far I had to drive to get there, who drove the car, how much food I'm actually going to eat, whether it's new or it's familiar food, what time of the day it was, whether that food is liquid or solid. We might also include here whether I had rescue medications. And the rescue medications really come back to that question, do I feel like I can manage symptoms when they come up? Some of our patients are going to say, yes, when I take Zofran, I am not nauseous anymore. Okay, that's great. We might put rescue medications. They could fall down toward the bottom of the ladder in some of my earliest exposures if I'm going to trial a new food and I'm going to either prophylactically take a Zofran or I'm going to take it after. That's still reinforcing to the brain, okay, food may not be quite so scary. That's okay with me in the beginning. Over time, the patient will become more and more comfortable moving to higher steps on the ladder. And we can also have them do trials with delaying using the Zofran, with going to the restaurant and not bringing the Zofran in my pocket. So I can vary the risk even with my use of rescue medications. And so I hope patients can see that as part of their journey too. And I often see the slower we go up this ladder, the more durable change that we actually see in food reintroductions.
Oh, I would also say just real quick with that too, as patients are using rescue medications, I'm trying to teach them pro-parasympathetic behavioral exercises. So we may be doing hypnosis with them. We're always basically doing diaphragmatic breathing, things like that, even post-eating, so that we can try to get a replacement behavior there eventually as well.
So this is where I get to come in as part of the team, and this is like building food acceptance. How do we actually get food into the diet? Where do we start? So one of the therapies that Dr. Loop and Dr. Simons was bringing up is this exposure therapy, and we can use that with food too. Small exposures over a period of time, minimizing risk, kind of framing it as, is that 1 or 2 bites, is that 1 or 2 tablespoons of fruits, blueberries, vegetables, whatever, is that really going to make or break your gut while you're eating foods that you're comfortable with, and trying to like build up their confidence around those types of foods. We see this a lot in pediatrics when you're having, picky eaters, quote unquote, and it, even just trying one food for 8 to 10 days before reintroducing another food. So very similar to what Dr. Simons was saying too, is that we don't have to do the whole serving, right? We don't have to work on getting the whole volume in, and we can start with very small amounts, building that confidence, minimizing that risk, and trying to reinforce that food is a friend, and that you can, the gut is more tolerable than you're, letting it on to be. If that food exposure therapy, those small amounts very frequently, doesn't work, sometimes we can do food chaining. So adding desirable foods with more comfortable foods in a progression so that patients can feel more comfortable and have desired outcomes from clinicians. Next slide. So this is an example of food chaining, and this is a pretty simple one, but it gets the point across. Find a food that the patient is wanting to try and willing to add into their diet. For example, this one's broccoli. So how do we get bites of broccoli into the diet? This particular patient's really good with cheesy rice. Rice is really easy. Maybe they're doing a low lactose cheese and it's just really jiving well with the belly. You'll often find that your patients are very comfortable with salty, starchy foods. So how do we chain those comfortable foods to get our desired food? So we can add a few pieces of broccoli into your cheesy rice, right? You're already familiar with the rice and the cheese. Now we're just adding a few pieces of broccoli to make you a little bit more comfortable. Once you are more comfortable with your casserole, now you can take off one of those ingredients. So I think it's really easy to do cheesy broccoli now instead of that rice. Still comfortable with it. It's still one of the foods that you're familiar with. You already know that you can handle bites of broccoli, so let's step it up. And then last, chaining is then just trying the broccoli on its own, whether, it's a small side portion. You can even have it with separate cheesy rice, but on its own, to kind of complete that food chaining. And then that's a success. Okay, we've introduced this into the diet. You don't have to have it every day. But food chaining can be really helpful when you're having a patient very anxious around foods and trying to tell them, okay, well, these are comfortable foods, so let's add a risk to something that's more comfortable to help minimize your brain around that risk.
Kendra, I was just going to ask, a question had come in about nostalgic foods. And what is your feeling about that, where patients feel that when they were younger, they had some safe foods that they really enjoyed? How do you is that something that you feel is a good option to start with?
Absolutely. Yeah. Nostalgic foods can be helpful, especially if they're already eating them. Or I have multiple patients that say this is like my safe food list or my flair food list. And I'll be like, okay, well, let's choose one or two of them that you feel comfortable eating often that we can then tack on a new food to. What Dr. Simons was saying about the mice study is that even if you're nauseous with familiar foods, those mice still went back to those familiar foods. So I think that can be a really good example for food chaining. Yeah, great question.
Well, and one of the things I would say about that, Dr. Russell, is that when something is associated together, so if this stimuli is associated with this, so in this case, food is associated with warmth and comfort. If this food shows up and it means warmth and comfort to me, it's likely to elicit feelings of warmth and comfort in me and allow for a more like parasympathetic response as we start to eat.
Yeah, good point, Dr. Luke. So now what do we do? I love the frequency, volume, duration example that Dr. Simons gives. That's kind of goal setting 101. And one of my favorite self-help books, they talk about how to achieve healthy habits and goals. And this is how you do it. You start with frequency over volume and duration. The brain likes small chunks, right? It's a lot easier to convince yourself to run 10 minutes, 5 days a week instead of running twice for 60 minutes, right? It's like that long is too hard for me to do. So now that broccoli's in the diet, we can work on maybe adding it a little bit more often. Maybe 3 days a week and then 5 days a week. We don't have to increase volume. We've added that food. And then if they, kind of two ways that I like to go as a clinician. If they want to add more volume, we'll step it up. If they want to increase diversity, we'll pause there at that small amount and move on to a new food. You can still build, get your servings of fruits and vegetables in small quantities, just more often. And that's the whole point of the frequency step. So if they're open to adding another food into the diet, we can either use that exposure therapy, small amounts, on their own, or we can do another food chaining, example with a different type of food. Next slide, please. So this pyramid was built for, just recovery of just eating disorders in general. And it's like, okay, what foods do I start with? And I always like to consider their whole background, their whole picture, right? Do they have gastroparesis, Crohn's disease, IBS, ostomies? Like, what are going to be layups? Because I always like to start with the easy ones to help build that confidence around eating and kind of shake off some of the scaries away from adding new foods in. So sometimes, when you're making a to-do list, you put brush your teeth on there so you can cross it off, right? It feels good to accomplish those things. It feels good to add in some easy foods and get some solid wins. Also, maybe that, patient is having struggling with malnutrition and we need to focus on calorie dense foods. Maybe we don't focus on fruits and vegetables right now because, their goal is to gain weight. And even just starting with that, have some every day from this real food guide, that might be lower roughage foods like peanut butter, avocado, olive oils for that patient who's looking to gain a little bit of weight. These are oftentimes like easy sells too, because they don't have a lot of fiber in those foods. So it's like, low fiber foods tend to be like pretty easy to convince patients to eat a little bit more of. Also, protein is that another easy sell. Leaner options are better tolerated. We do restrict all foods in some patients with ARFIDs, including, food groups like proteins as well. And then, of course, like changing the texture of that food, I think can be a win as well. If they're stuck on smoothies or liquid soups, like, okay, let's add in like 2 tablespoons of frozen blueberries to your shake. Like, let's do another blended carrot into your sweet potato soup or something that's orange, and kind of like, mask it a little bit, kind of trick your brain into, handling that new option. Typically like to stray away from maybe doing some gassy vegetables and fruits at first, just kind of like what we were saying about easy wins, layups, gravitating more towards, foods that are often well tolerated, even with the most like strict elimination diets.
I want to also pause here, like at the top of the pyramid, it's talking about eating out socially with friends and family. And I think we can see food avoidance as it relates to the specific foods that I'm eating, but we can also see that significant avoidance of social eating opportunities. And I think with patients, these are 2 separate goals that we can practice. And sometimes working on the social eating can be in first before we start to expand diversity too, is like, okay, can I practice inviting someone into my own home at the meal of the day that usually goes the best for me? I eat my safe food and they eat their food, but we're eating together. And then I move into different levels of risk exposure with just being in the presence of other people, eating my own food, being around other people while I'm not eating, but they are, being with other people when I order something at a restaurant. And I can kind of scale that step up. But helping patients differentiate, like it would be very challenging for me to eat out socially and eat new foods at the same time. And so I want to help patients find easier ways to accomplish this.
Absolutely. I also think too, like with eating out, especially with patients with celiac disease, where sometimes you do everything that you can in your health, in your capabilities to protect your health, but then ultimately you leave it up into someone else's hands, right? The servers, the chefs, and that can be very intimidating for, patients with celiac disease, but we still want them to live, a normal life as possible and still have those social experiences. So trying to, minimize the risk and talk about like healing and bounce back, and is part of what we do too, is through those types of populations. So we have a case study that Dr. Luke kind of brushed on that we see often here in our clinic, but any sort of stricturing disease, we've picked stricturing Crohn's disease here. Just a very generic like medical history background. That's not the point of this whole thing. So we have basically a new patient with Crohn's disease that went to the ED with severe abdominal pain. They found a bowel obstruction and it was pretty severe and she needed emergency surgery. She was just, recovering well, advanced to soft diet, discharged home. She's not on any medical therapy at this time. Next slide. And then at the GI follow-up, this is very popular right now in IBD settings, is surgical intervention and then medical therapy to, prevent any, future inflammation. Started on medication and everything looks good. Biomarkers are normal. Small bowel imaging looks good. And this oftentimes happens is that some patients can be in a surgical remission as well. But what Dr. Luke was saying is now this patient is getting a lot of abdominal pain after eating. She's very anxious around food because she's worried about getting another bowel obstruction. That was a very traumatic experience for her, and she wants to do everything in her power to have that not happen again. She's even had a lot of severe abdominal pain that has taken her to the ED. And when they have done workup, they have not found any new strictures. That anastomosis site looks great. No signs of other intestinal obstruction. So, just kind of she feeds off of, what's happening, more restrictive. Anxiety around food gets a little bit worse. So my role as the dietitian coming in here, I take a diet recall. This happens often, they're eating a lot of salty, starchy foods, toast, peanut butter, soups, chicken and rice, no veggies, very limited fruits. And I typically ask the patient then what their goal is. Do they want to expand their diet? Is there a food group that they miss a lot or that are more open to eating? So, we can try food exposure therapy first. I like to choose a food that's typically not gassy. I like green beans because since we live in the Midwest over here, we can get green beans at any time of year, whether they're canned or frozen or fresh in the summer. So they're always available and they're affordable. So I always like to think about that too. Maybe we start off with just 1/4 of a cup, add it a few days a week. Then once that works for 3 days a week, increase it to 5 days a week. Maybe then we advance it to 1/2 cup, back down on the frequency. There's a lot of flexibility here on how the patient is open. If we do need to use a food chaining example, I always like to use soups and smoothies here because it's easy to sneak them in, right? Think of like a little kiddo. It's easy to throw in some cooked carrots in a chicken noodle soup, and then eventually maybe just doing noodles and the cooked carrots, and then eventually peeling off and just doing the cooked carrots.
Where does the GI psychologist sit in this picture? I think there's a few roles that we can play. One, we circle back to that overall message we wanted to convey earlier, which is that pain may not mean that there's a bowel obstruction, or does not necessarily mean that there's a bowel obstruction happening. So we may want to help to create some distance between them and that thought process that they're having. It's possible we would need to do some trauma-focused intervention if the bowel obstructions and the surgery was considered traumatic to them. So we'll want to work with the thought processes. We may help to reduce the visceral sensitivity, that nerve communication, using strategies like gut-directed hypnotherapy, using neuromodulators if that seems appropriate, and then also helping them to reduce the amount of symptom-specific anxiety that they have around bringing in these more fibrous-based foods. And so as we wrap the conversation today, I think there's 3 main things for us as providers. It's so important that we help our patients optimize their symptom management. We cannot do food exposure work when patients are in really significant symptom flares, again, because their brain is really too vulnerable to associations there. We want to help them liberalize their diet as opposed to overly restrict it, and find ways to feel confident around food and eating. And we want to help reduce the amount of anxiety that they experience about symptoms. And for a lot of our patients, this is even just giving them a place for them to express how difficult things have been, and being that compassionate, listening ear for them that is non-judgmental about what their experience is. And so we'll open it up for questions that people may have now, and I'm going to stop my screen share.
I did want to address, Dr. Williams, you're absolutely right. Eating did not cause the intestinal obstruction. And this fear that shows up and the pairing that shows up is automatic. It's classical conditioning that shows up. So if I've eaten something and this shows up, my brain automatically connects it. It was the food that did it. Even though in this case, I completely agree, it was the Crohn's disease that caused the stricture, not the food.
So as a dietitian, I'm always very curious because I don't work with this population. What about, this might be more for Kendra, when we're looking at the potential for vitamin deficiencies, what lab work would you be looking at to be monitoring and then, having those repletion guidelines?
That's a great question. So I also like, especially with lab work, you want to look if they've had any bowel resections, especially small bowel resections. It's very popular to do, B vitamins, iron, and D in those populations. Those are also the vitamin D is really great because a lot of people do restrict dairy, having like lactose intolerance issues. So I always want to make sure that those are okay, and if they're getting some sort of calcium as well. And then if they've had a lot of like blood loss, like blood in the stools, more for like ulcerative colitis, that could be like good for iron studies as well. And then, of course, if they're showing signs of micronutrient deficiencies, like in their mouth, in their hair, and their nails, then those lead to specific, micronutrient labs too.
Do you recommend just a general multivitamin and calcium and vitamin D for a lot of your patients, or is it more specific for what the lab work comes back to look like?
I think every dietitian has a different answer for this, but I love a multi just because we do live in Ohio. We don't see the sun half the year. We don't have access to fresh fruits and vegetables during that time. So it's a good place to cover your bases. There are a lot of really good USP, like certified, very affordable vitamins and minerals that I'd like to recommend to patients, especially if you're trying to just say, hey, let's just, while you're restricting, while we're adding some back in, and while our diet's a little bit limited, let's just toss this one on there. Like, it'll be fine.
No, I agree completely. What are your thoughts, and this can be for all the panelists, what's your thoughts on an over-the-counter probiotic? Because a lot of times we know that they're just not getting in the biodiversity that they're looking for. Is that something that you would recommend, or is that something you would prefer just to depend on the food?
I think the evidence is somewhat lacking around probiotics when we take it empirically. And so some patients may anecdotally say that a probiotic has made a difference for them, but when we've actually compared the studies, the evidence just isn't there to support it globally for all patients. I think in general, the recommendation is that those fermented foods come from the diet, if at all possible. So yeah, I wouldn't make a strong recommendation for all people to be using them.
Yeah, I think there's a misconception that they can get this from over the counter and not actual from the whole identifiable foods themselves. So
yeah, I get that a lot with like I'm sorry.
No, go ahead.
With like greens and powders and like fruit and veggie powders, a lot of patients will say, well, at least I get something. I'm like, well, less supplements are better. I'm definitely like less pills in the pill box, less supplements, because the biologic availability of those red and greens powders are just so poor. I wish they worked, but they just don't. And I'd rather have you get them from foods, and maybe even too, some ingredients in that green powder could be triggering a symptom. And now you're just kind of back to where you started. So to what Dr. Simons was saying about the probiotic.
And I think that like the overall like consensus in the field is like, okay, probiotics, they may be like a cherry on top, but the real bang comes from fixing your diet and fixing like what you're putting in and managing stress and taking care of your body.
There's a question in the chart that is asking about transitioning of inpatient from TPN to either to oral or to enteral, and how do you have that conversation with the patient? How do you devise a plan? What all kind of goes into preparing the patient to transition over to more, either enteral or PO?
Emily, I think you're raising like the most difficult patient that we all might encounter. And so I just want to highlight that for a moment, is that I don't think we have all the answers for these patients. I do think about sometimes that, this is separate from TPN, but just the idea of like continuous enteral nutrition versus solid foods. With continuous enteral feeds, we have persistent pressure being put on the GI tract, where the patient doesn't really ever get a break from nutrition entering the system. And so sometimes patients end up doing better with collected solid food feedings than having nutrition running all day long every day to meet their needs. So I do sometimes have that conversation with patients of, is it possible we could use rescue medications around the oral eating experience that make that more tolerable than having 24/7 feeds? But as far as answering this question of TPN dependence in our patients with DGBIs, we don't have a good answer for that. Even using our tools like gut-directed hypnotherapy and neuromodulation and antihistamines and all of those things, I don't know that we see a lot of movement there. And maybe Kendra or Steve feels differently, but I think that's the biggest challenge we all sit in.
Yeah, I have a lot of patients come to me on TPN, and while I don't manage the TPN, we talk about like, okay, how do we get you off of this? Because we know that in hopefully most cases, it's not a long-term solution. So of course, like cycling the TPN could be helpful, so that way you have some windows, and then also using it as a frame is like, okay, this is bonus, this is extra, you're meeting your needs calorically, like, so what's the worst that can happen? Like a couple tablespoons of this, throw it in there once a day, see how it goes, and continuing to use those, like the kind of like the pediatric example, like those small exposures, 8 to 10 times, tastes, that way it's not, they don't have that pressure of, oh, I need to eat or else I'll lose weight, because they have the TPN in the background. It takes that mental load off too.
Yeah,
Well, and I think you raised like the hypermetabolic state that some of these patients are in, where even if they can take in food orally, they may not be able to take in a sufficient calories to match this hypermetabolism. And so that's a tricky situation that we run into also. Like for the average person, they're consuming enough calories, but it's not enough to prevent weight loss.
And sometimes we have to start really, really slow. I've worked with patients who Kendra's trying to get them to expand their diet, and it's like, can you eat one blueberry and see how that goes, or 1 teaspoon of yogurt, and we just work from there. And like Dr. Russell was even saying, validating emotions can be very, very useful. Validating anxiety around this. This is scary and this is hard.
I'm just curious, years ago when I first started the clinic, I worked in pediatrics, and we had a feeding clinic where we would actually make smoothies for the kids and have them try different textures. Is that something that you would do in your clinic, or do you have them trial the different foods at home?
We don't currently have it built into clinic for them to try foods in-house. I mean, I think that would be a good extension of what we're doing. At Cleveland, we're treating patients all over the country for the most part. So I'd say a lot of my complex patients are not even located in Ohio. And it might be difficult to provide them nutrients on the spot.
Yeah. And now I know I'm getting Kendra a Vitamix for Christmas so she can start making the smoothies.
I have a Ninja. I love my Ninja. It's incredible.
No, thank you. Really, thank you. I have learned so much from this presentation, and I'll be able to use some of these techniques with my post-bariatric patients, actually. I think it's going to be really helpful.
Yeah.
I think Renee has some closing words for us.
Yeah. Just coming off mute. Thank you all so much. That was such a fantastic, engaging presentation. I think so much to take back and see how we can, everyone I'm sure is able to take something back and improve the patient care they're providing. So thank you all so much. That was fantastic. Our last Nutrition Live for 2025 is December 2nd on the topic of heart health. So we hope you all will join us then. Next slide. All right, and again, there's so many more opportunities to join in other educational events. The virtual Global IBD Visiting Professorship is Tuesday, October 21st. And again, more information, you can register using the QR code. And again, like I said, you can fill up your entire calendar with all of the amazing education and all opportunities through DDI. So more information on the QR code and on the website. And I think with that, we will conclude Nutrition Live. So thanks again to our presenters. Fantastic presentation. Hope everyone has a great evening. And we'll conclude with Go Guardians. Have a great evening, everyone.